the slides were created as collaboration with Nancy Glass, who is on the call today joining us from the School of Nursing, Jean Anderson and Jean Keller. Have a relatively small group, so if you all have any questions along the way, please feel free to ask. So Bartlett Bridges is it's a new initiative. Nancy and I are co-PIs on an RO1 that's supporting this study that's really looking at implementing an intervention for women experiencing IPV in the Bartlett practice. So I'm gonna do some background about IPV in terms of what is IPV, what are some statistics, how does it impact people with HIV, and then introducing interventions that can support people experiencing IPV, and then go through the study. So what is intimate partner violence? It is the occurrence or threat of physical, verbal, sexual, emotional, or psychological abuse by a current or former intimate partner. It can vary about how often it happens and how severe it is, and it can range from one episode of violence to chronic and severe episodes over multiple years. And it can include any of the following behaviors: physical violence, sexual violence, stalking, and/or psychological aggression. We know that IPV is common. So nationally, 1 in 4 women reported completed or attempted rape during her lifetime. And 1 in 9 men reported being made to penetrate someone during his lifetime. In terms of lifetime reports of sexual violence from the U.S. Women and Men National Intimate Partner Sexual Violence Survey 2016-2017, high rates of contact sexual violence, rape, sexual coercion, unwanted sexual contact, sexual harassment in a public place were reported. And then for people living with HIV, this was one study that showed that among people living with HIV, 25% reported physical violence by a romantic or sexual partner lifetime, 4% within the last 12 months, 17% during their lifetime had experienced forced sex, and then 1% in the last 12 months. And then, if you look, depending on the population you're talking to, depending on how you're doing these assessments, one primary care HIV clinic found that 73% of the sample reported lifetime IPV and 20% reported current abuse. And more than a quarter of those abused felt that the abuse was related to their HIV status. We also know that there are interrelationships among IPV, mental health, and substance abuse. So among IPV survivors, there are higher rates of trauma-related mental health conditions, nearly 3 times the risk of developing a major depressive disorder or PTSD. Women with a recent history of experiencing IPV had nearly 6 times the risk of problematic alcohol use. And then the prevalence of substance use or abuse among IPV survivors ranged from 18 to 72%. And among survivors of IPV, substance abuse ranging from 31 to up to 90%. Depending on the population sampled. And then for women living with HIV, looking at those intersections of IPV, substance abuse, and depression, Women with HIV experience more frequent and more severe IPV than HIV negative women. So again, there's all of these different, sort of percentages being reported. So 55.3% of HIV positive women experience IPV, so 2 times the national rate. Rates of sexual child abuse, 39%, and childhood physical abuse, 42%, so greater than 2 times the national rate. 40 to 50% of people with HIV in the US have a history of alcohol abuse or dependence, and about 10% of new HIV diagnoses are related to injection drug use in the past. Depression is the most common psychiatric comorbidity among people with HIV. So it affects 30 to 40% of people with HIV, 3 times greater than the general population. Women with HIV, 2 times more than men, likely to have depression. Living with substance abuse, IPV, and HIV is associated with an increased risk of depression. In one study, women who had experienced substance abuse, violence, and HIV, so all 3 of these factors, were 6.8 times more likely than women with none of these factors to have depressive symptoms. And about 50% of those with depression go undiagnosed, and 50% of those who do have depression recognized go untreated. And we know that depression is associated with decrease in antiretroviral therapy adherence, missed HIV primary care appointments, reduced viral suppression, higher rates of AIDS-related morbidity and mortality. And women with a history of violence or living with HIV are less likely to be virally suppressed. So 76.4% versus 93%. Experiencing physical and other types of IPV increases for women, increases the likelihood of not getting tested for HIV, not linking to care, and then again, poor adherence to ART among women who use drugs. And then having a history of childhood sexual abuse is a strong risk factor for failing to engage in HIV care and medication adherence. And then several studies have shown an association between alcohol and illicit drug use and poorer adherence and detectable viral loads. So I think, all of us have seen people who have experienced IPV and the co-occurrence of substance use, mental health issues, and then struggles with adherence and health outcomes. So, because of the prevalence of IPV among people with HIV, because of the significant impact it has on people with HIV, thinking about how we as healthcare providers can play a role in supporting people who have experienced or are experiencing IPV is very important. And I know it's something that we all have thought a lot about and, have had varying success in terms of supporting our patients who have experienced or are experiencing trauma. So we as healthcare providers, we, identify multiple complex unmet health and social issues daily, including intimate partner violence, also including housing instability and food insecurity that we know negatively impacts the health of our patients. We also know that there are wonderful community-led organizations that have expertise and resources to provide services and advocate to meet these complex and unmet health and safety needs. Can really help support people obtain safe and affordable housing, food security, and social support. And if we can build and strengthen bridges from us as a clinic, as healthcare providers to community partners, we're more likely through collaboration to be able to meet the health and safety needs of women living with HIV in Baltimore. So that's the sort of the genesis of this project. So, what are the components of trauma and violence informed care? There are clinic based interventions that we can employ. I'm going to talk to you all today about a concept called universal education that allows for informing people who come through our clinic about what is IPV and resources without requiring disclosure of IPV, but also while signaling that we are a place that can support you if you are experiencing IPV. When people do disclose that they're experiencing IPV, having training, having the resources to provide counseling, some initial safety planning, and then doing warm referrals to our community-based partners who have more experience working with survivors of IPV, working with people who are experiencing IPV. And then through that community collaboration, providing that additional counseling, safety, planning, and advocacy opportunities for safe and affordable housing, food security, and social support. And then Dr. Glass, who's on the call and is a wonderful colleague from the School of Nursing, she has developed a My Plan app, which is an app that has been used internationally, validated in different settings to support people who are experiencing IPV, giving them information about resources, really helping them connect with these supportive services to help them get in a safer and more supportive situation than the one that they're in. So CUES is an approach of offering that universal education about IPV. It's an evidence-based intervention to address domestic and sexual violence in health settings, and has been shown to improve health and safety outcomes for survivors. The CUES stands for the four main elements of the intervention, and that is confidentiality, this universal education, empowerment, and support. When we talk to survivors about what they would want from providers, from clinics, is to be non-judgmental, to listen, to offer information and support, and to not push for disclosure. IPV is obviously a very sensitive kind of relationship, right? It's a situation that is very sensitive. There are a lot of complex feelings, and also there's some danger that women may experience if they do disclose. So CUES is a way to help people who are experiencing IPV receive important information. Some women may, and some people may not even realize that they're in an abusive relationship. Giving information about what IPV means and what are resources and support without requiring disclosure is a key element to this. And then for people who get the information, if they are not currently experiencing IPV, they may experience it in the future and they will be empowered with that information. And or they may have family or friends who are in these kinds of dangerous relationships, and they could share that information with family, friends, and community. So again, universal education provides an opportunity for clients to make the connection between violence, health problems, and risk behaviors. So, we are, as healthcare providers in the medical profession, we are trained to screen, ask, and then ask our patients to let us know what it is that they're experiencing about health behaviors, things like that. And so it is a different kind of approach to offer information without requiring disclosure. There's some gatekeeping involved if we only give information if somebody tells us that they're experiencing IPV. So it's interesting because in terms of sort of grant funding and like showing what we're doing, screening is important in that perspective so that we can say that we, ask these certain questions to this many people, which we can do, but we also need to recognize the limitations of screening. And so by partnering screening with universal education, providing universal education ahead of time, it will make the messaging that much more impactful. And, again, be giving it to people who may not feel comfortable disclosing to you or to whomever is asking them those questions. So the first step in cues is confidentiality. So before we introduce the topic of IPV in the course of offering universal education, the person you're speaking to may disclose that they're experiencing IPV, but part of the decision about disclosure is about confidentiality. So we need to ahead of time inform patients about any reporting requirements, any limits of confidentiality that we have. We want to see people alone, by themselves, so that they can discuss their any relationships and any violence in a safe manner. And then, we never should be relying on family or family members or friends for interpretation services, just as a matter of course. And we have access to excellent interpretation services. So part of what we'll be doing with our intervention is having some scripts and, that sort of starting point for having the conversation about IPV. The UE part of cues is universal education and empowerment. So what we do is we sort of describe what it is to what is IPV. And then there are safety cards that have the information about IPV along with resources that you can give to people. So again, the conversation is, educational. This is what IPV is, and then you're giving them cards that includes that information along with resources. Open the card and encourage them to take a look at the card and make sure that they know that we're a safe person and place for them to talk to. And again, offering these safety cards to all patients ensures that everyone gets access to the information about relationships, not just those who choose to disclose. So here's one of the scripts. I'm giving you two of these cards to all of my patients. They talk about relationships and how they affect our health. Take a look, and I've also included one for a family or a family member or a friend of yours. And then on the back of the card, there are resources you can call or text, and you can always talk to me about how you think your relationships are affecting your health. Is this any part of your story? And then they can choose to disclose or not. And the safety cards that are being developed for our clinic will also have some Baltimore specific resources. And then the last part of cues is support. So that, with universal education, the goal is actually not disclosure. It is, again, providing information about IPV and information about resources. And but disclosure will happen. And so we want to be prepared to support people who do disclose that they are experiencing IPV. And with that is, we will have some initial ability to do some safety planning, and then this warm handoff, we're collaborating with House of Ruth on this project. So making a warm referral to local domestic or sexual violence partner agencies. There are some national hotlines as well. And then some health promotion strategies and a care plan that takes surviving abuse into consideration. And so then, we'll have this compiled. We have resources already, but also have it at the ready, including on some of those safety cards, on the safety cards about the resources available in our area for survivors of domestic and sexual violence, taking into consideration LGBTQ plus identifying patients, immigrant or youth survivors. And so, if somebody does disclose, we'll have trainings on the entire CUES process, including the support piece. Thank you for sharing this with me. I'm so sorry this is happening. What you're telling me makes me worried about your safety and health. Normalizing the experience. A lot of my patients experience things like this, and there are resources that can help. I would be happy to connect you today if that interests you. And then really understanding that some people are not in a place where they are going to do anything different at that time. Continuing in the relationship may be part of it. There may be some complicated economic and other factors at play in terms of the violent relationship. And so really, making sure that we move to a place of real support and offering resources, but it's ultimately the patient who will decide what they do or do not want to do. So I think I'm going to pause before I move on and see if anybody has any questions or comments at this point. Or I can continue. I don't know if Nancy or Jean, if you have anything else to add from what I've already presented.
Hi, go ahead, Nancy.
No, I was going to say, I think you've done a great job.
I was going to say the same.
Okay. All right. Then I'll just go ahead and continue. Am I sharing my screen at this point?
Yes.
Okay. All right. So the study aims of our Bartlett Bridges project is for aim 1, and this is where we are right now. So collaboratively adapting a trauma and violence informed care intervention along with the MyPlan app, and tailoring it to our clinic, to our patients, to meet the complex health and safety needs of abused women living with HIV. In our aim 2, we will be examining the effectiveness of the adapted TVIC and MyPlan intervention, looking to see if it does reduce health disparities for abused women living with HIV. And then in aim 3, we'll be assessing the mechanisms, facilitators, and barriers to implementation of a clinic community trauma and violence informed care and MyPlan intervention. So again, we're in aim 1 right now. There has been a Hopkins Community Partners and Advisory Board that has been meeting, along with interviews and focus groups of women living with HIV and AIDS and IPV, clinicians and advocates. And we're in the process of now, what we'll be doing is identifying some champions, having more in-depth training around CUES, training on how to deliver the CUES intervention. And then along with that, I'll be explaining to you later, we have a trauma-informed care leadership group in the clinic that has been meeting and developing how we're going to be implementing this intervention. So along with the champions, champions from the clinic. So that's going to be providers, nurses, navigators, social workers, case managers. We'll have champions. There's folks from the leadership team that are also going to be champions, and will be developing the intervention specifically for our clinic. And doing that in collaboration again with community partners and women living with HIV/AIDS and who have experienced IPV. We're going to pilot test this, and this will again inform the implementation, and then we'll be doing a rollout looking to February to be able to do sort of an all staff training and then implementation of the intervention. In AIM 2, we're going to have that intervention. Oh, this is still AIM 1, sorry. AIM 2 is to examine the effectiveness of the adapted intervention in reducing health disparities for abused women living with HIV. So we're going to be doing universal education, and then women who identify as experiencing IPV will be enrolled into a study to look at the impact of the intervention on their outcomes. And then women who are living with HIV who are not experiencing IPV will also be enrolled, and we'll be looking at baseline 3, 6, and 12-month outcomes along the way. And so the hypothesis is that women experiencing IPV will have who have poorer outcomes at baseline than women not experiencing IPV, that those outcomes will approach or even meet that of women who are not experiencing IPV through this intervention and through this collaboration with House of Ruth and these additional supportive services. So again, we'll need to have the intervention be, well developed, implemented, and then we'll start enrolling women into the study. So this will be self-identified as a woman, so cisgender, transgender women, age greater than 18 or older, living with HIV or AIDS, able to complete their surveys in English or Spanish, and then receiving care through the Hopkins HIV Collaborative. So that means in the Bartlett clinic, through the Women's HIV Health Program as well. And then, enrolling 200 women with HIV experiencing IPV, 200 IPV negative women. All IPV reporting women will be invited to join the study, and it'll be a random sample of women not experiencing IPV who will be invited.
Joyce?
Yes.
Are you forwarding slides? Because it's not forwarding on my screen. I don't know if that's true of everybody else.
Oh, is it not forwarding for you all?
Yeah, but somebody else speak
Okay.
up. It could just be me.
I still see study aims.
Oh, whoops. Okay. Let me stop my share. Okay, let me see if this works. Are you seeing movement now or no?
Yeah, yes, it's moving.
Yes.
Okay, I apologize.
Okay.
So this is the AIM 2 piece about the intervention, and the women who are experiencing IPV will get this, enhanced intervention that we're going to be offering with the universal education, advocacy, and coordination with our community partners to address unmet health and social needs. And again, the hypothesis is that the outcomes of women experiencing IPV will approach or even meet that of women not experiencing IPV. This is our sample size to enroll 200 women who are experiencing IPV, and then a random sample of women not experiencing IPV will be invited to join the study. So our outcomes are going to be HIV-related outcomes, viral load, CD4 count, adherence and retention to treatment and care, through the medical record. They'll be getting surveys about adherence and self-efficacy, and then some mental health, depression and PTSD scales. And then also evaluating safety behaviors and resources, housing stability, and then food security. And then in the medical records, again, the labs, as well as documentation of the intervention, IPV disclosure, and then adherence and retention. And then aim 3 will be to assess the mechanisms and facilitators, barriers to implementation of this intervention in the clinic. That's the aim 3 of our study. So just again to, circle back to where we are with aim 1, we're in the place where we're adapting and, going to have this content for our intervention. And we are have this Bartlett trauma-informed care leadership team. So it includes our nurse manager, Sheila Goldscheider, Jean Keller, who co-directs the Hopkins HIV Women's Program, Nick Schweitzer, who oversees our HIV psychiatry program. I'm the medical director at the clinic. Leon is one of our nurses who's been very involved in our leadership team. Allison Heinrich is our HIV/AIDS program manager. Thomas McDonough is our assistant director of social work. Latasha Davis is one of the community outreach coordinators through the HIV Women's Program. Allison Livingston, also with the nurse with the HIV Women's Program. Megan Narauki, I'm just putting her there because she was very much a part of our group, and she was a nurse practitioner with the Bartlett HIV Psychiatry Program. She has since left, but has been really instrumental in us sort of putting together what would be appropriate workflows and ways that we can implement a trauma-informed care approach for patients. We also are inviting additional nurses, providers, and then staff to become champions, right, for this. And the champions will get trained on the CUES intervention. They will pilot it. And then in the course of them sort of being trained, piloting it, we're also going to be working on actually what's the implementation and workflow going to look like. We're going to have an all staff training where we want the clinic as a whole to understand about CUES, understand about the intervention, and then these champions will continue to be champions for the implementation throughout the time of the study, and then honestly beyond. So this is wanting to, again, provide that clinic-wide ability to really provide this really important information. And then for people who are experiencing IPV, survivors of IPV, for us to be a place where people can really feel comfortable to share what they're experiencing, and then we can effectively connect them to resources when they're ready to do so. I didn't put Surabhi's last name. Surabhi Kuke She is our IPV expert who we've actually been working with her for the last several months. She's really wonderful. She has decades of experience in IPV interventions and implementations in clinics, including HIV clinics. And she is our main consultant who's going to be giving us technical assistance and support as we implement this intervention. So that is the end of my presentation. Does anybody have any questions or comments, thoughts? It's very quiet.
Looks good, Joyce. Great job. I did just have a question, which I think I must have missed at the beginning. So are these two like different interventions that are being put together for the first time, or is it all one kind of established intervention?
So the CUES is an established intervention. And I don't know, Nancy, if you can speak to CUES paired with the My Plan app. I mean, I think that, you know, this is obviously new for us, but, you know, we just really compiling all of the resources, you know, to help support women. And then I think really crucially that community connection as well.
Yeah, so the CUES intervention has been tested and validated in several settings, starting in family planning centers. Planned Parenthood is when they first started really working on this. And then has been moved throughout primary care and HIV. So this is the first time that we formally evaluated the CUES with My Plan. They've been evaluated and evidence-based separately, but we're trying to do, you know, My Plan is a tool. It's a tool for an additional resource for providers and for the patient if they're interested in you know, and have time, maybe they could do it with a community health worker or outreach worker or the social worker or on their own in the clinic. So, or even on their own phone if that's available. So it's a tool that providers can let the patient know about, but it's certainly, you know, sometimes it can help them think through the questions they would like to ask a provider or the resources they would like to learn more about. So it hopefully can be part of that triggering a conversation with the provider.
Or with another trusted individual in the clinic, right? So it's interesting, I presented this work to our community advisory board, and some of the feedback that I got, and I think we experience this as providers, is providers are too busy. I want to spend my time focusing on my HIV, on my medical conditions, and you know, and they feel it, right? Like we feel it, they feel it. And so again, this is about implementation. How can we best, you know, offer these supportive interventions in a very busy HIV primary care clinic? Thanks for your question, Greg. Other thoughts, or everybody's being so shy and
Well, you know, I think you covered everything so well. And what people might know is this process we've been working on now for several years. And what triggered the process was that we know our providers don't have time to do this. And when somebody answers yes to a screening, what happens now? You know, how do we help them? So we've really done all the legwork, and in addition to your wonderful study that we're going to be doing so we can validate these things. But we did a lot of this legwork so that we have a process that hopefully will be smooth when somebody needs our help.
sustainable. I think, you know, we really, again, and I've learned so much by engaging in this work. I've learned so much from Nancy and Jean, and the cues just feels like such an appropriate intervention for this topic. It was kind of exciting to do the training with Surabhi, who's really excellent and is going to be a great resource for us as we again sort of, you know, adapt the intervention and then really begin to implement it.
Yeah, and I think it really says a lot about the clinic and the leadership around you know, having a group that's been working on trauma-informed care for several years, and then, you know, really this grant came from a conversation that Joyce and Jean and I had, and we thought, okay, well, you know, we have an idea, we have this work sort of commitment, let's try to really develop an implementation and evaluate it. So it's been a really it's fun when everybody's really engaged.
Yeah, thank you, Nancy. Nancy wrote the grant. So
With a lot of
that's
help.
really so yeah, really excited to be able to do more. Yes.
Are you going to be looking for providers to volunteer for this? Or are you going to go out and recruit people?
Yeah, so I'm gonna be reaching out to folks. If there are people who could use some salary support. So Nancy brought up, we were just sort of, I was explaining to her about how busy everybody is. And so Nancy, you worked with JHCP, and you know, sort of the idea of being able to provide some support, whether it's through RVU offset or something like that. So I spoke to our ID leadership team, and I am able to pay for some salary support if people need to like buy down some clinic time or other things to be able to devote to this. You know, we have a relatively small number of people on the call now, but if you're interested, please do reach out to me, and would love to have many providers involved in this. I have wonderful, you know, nursing. Sheila's on the call right now. The nurses are committed. Social work case management is committed. The psychiatry team, Jean and the GYN folks, and then our navigator. So under Allison is one of our champions, Allison Heinrich, and our navigators, Glenn Fulton and Christian Means, they're gonna be champions, as is Leon. So I think as many providers that would want to join me, and I'll be reaching out to some individual folks as well. That would be great.
And I just want to add that this was really the leadership of Joyce in this process. And the dedication to everybody really meeting regularly. It's because it's been a few years and we are there pretty much every week, every other week. But Joyce really was a wonderful leader, showed us some wonderful leadership, and that's why I want to thank her officially.
Thank you, Jean. I appreciate it. It is, we have such a wealth of expertise and opportunity, and I think so much of it is having the bandwidth and the space to really sit down and just get it done, get all the players together. So I do think that commitment that the whole team has showing up every those 2 weeks, you know, it can be very slow going, but I think we've created a really great foundation among the leadership, among key folks, to be on the same page about what all of this means, have participated in the trainings, that we're in a good space to be able to, again, hopefully implement something that will be sustainable. So thank you very much, Jean. And thank you to Nancy for your your expertise and creating, I mean, this is creating bandwidth for us as well, through the study, and I think a really important study to just show that, hopefully positive impacts, and then how can this be done? What does it take to implement something like this in our busy clinics?
Yeah, I feel lucky to work with the Bartlett Clinic, so.
Other questions or thoughts? I mean, I know we could have some time back, but I personally feel like this universal education was a real eye opener for me. Just again, that idea that you don't need to screen, like you kind of are well informed and you're providing the information. Yeah, Allison.
Yeah, no, thanks, Joyce. I missed a little bit at the beginning. Jean did present on our toolkit yesterday, and one of the questions that I asked, well, first, I think it's great to be just increasing our capacity, just in an understanding, I think, of how to ask, and then with some opportunity to have a resource that we can share with people and to build from there. The question that I had yesterday, and I'll throw this out here, was about same gender violence, and IPV, because I think with our population of young people, that's a lot of what we see. And of course, we're starting here with women, but wondering what the next steps would be in terms of potentially being able to address that actually very prevalent problem that oftentimes there's not a lot of space for people to go or feel safe to go. So just curious how we go there next or concurrently.
Yeah, and I mean that's something. So Survey, she gave a training, I guess it was a couple months ago, to there were about 20 of us from the clinic, and that was one of the things that we talked about, was sort of making sure that we have the resources to help support people in same gender loving relationships, the making sure that we understand the complex dynamics of all of these, anyone who's experiencing IPV, and then knowing what those resources are locally as well, so we can connect people appropriately. So I agree. And then I think, Allison, as we do this work, having the champions, I think we want to have folks who, are being champions, not just to employ the intervention, but to inform it. Right. So what are some things that we need to bring in as we're developing in the intervention, as we're out, rolling it out, we will have a compendium of resources, but there's likely others that we should bring in, and this will be an iterative process ultimately.
No, I think it's great. Thank you for all.
Other questions? Or Tracy, I don't know if you meant to go off mute, but I see that you're off mute.
I meant to go off mute.
Okay.
Yeah, this is super exciting, of course, and I appreciate too, Allison, your last questions. For what kind of commitment are you looking for people from the clinic to support this initiative, in terms of time, and just as I think about, our team from Restore, I know you were talking with us about how we could support. What kind of time commitment are you looking for?
So for champions in the near term, there's a 2-hour online cues training. And then there's we're going to have an implementation meeting with champions, and then with the trauma-informed care leadership team, we're all champions, and then the additional champions to do the 2-hour online training. And then we have a 3-hour in-person implementation meeting with Survey. And that's actually already scheduled for December 9th, where we're going to be working with her on what is this? We already have an implementation, we already have a protocol to build on, but to have that be more informed with other folks, with the champions who are going to have done the training. And then there will be then a pilot testing by the champions for a couple of weeks after our implementation meeting. And then in that course, we're going to be refining after that pilot. We'll be sort of finalizing our intervention protocol. And then the champions will meet with Serby for about an hour to do a debriefing on how the pilot training went. And then those champions will be part of that all staff, training that we'll have, and then be a resource for the clinic, for the Qs, and then as we're implementing, if there are changes that need to be, if we need to be doing some things differently, be sort of the champion for the intervention.
Fantastic. Thank you.
Yeah.
Joyce, sorry, I don't know if someone else was ready to talk, but do you think this would be anything that maybe like more thinking about like the fellows, if any of them, like the upper fellows would be interested in? Like, or do you think that you want some people to more be like a continuing
Yeah, I mean, I think we could think about it. I had really more thought about folks who were going to be in the clinic longer term, but I think, I'm interested in, we should talk some more about what you're thinking about, because I guess in some ways then no matter where they go, they will have had some of this kind of experience. But I think, yeah, my inclination is not to be a champion, just because, they're probably going to finish with their clinic time and then, be moving on to other things. So they, won't be in the clinic for longer. But I think as much as anybody wants to be involved and learn, it's very welcome.
Yeah, I'll just mention it to some people and see how they feel.
Okay, great. Okay, well, thank you for all the positive feedback. Thank you to Nancy and to Jean and to Sheila for just your collaboration and support and guidance. And I think that again, I have learned so much by really delving into this, and I'm looking forward to learning even more and doing this work with all of you. So thank you so much. Okay. All right. Happy Halloween, everybody. Have a good weekend.
Have a great weekend. Take care.
Thank you.